begin this lesson, let's consider a very serious injury. A young man was badly injured in a motor vehicle accident, and his 6th and 7th cervical vertebrae were crushed. His spinal cord was essentially severed at the level of this fracture. As a result of this terrible accident, will he be able to take a deep breath? In fact, will he be able to breathe on his own at all? Or will he require a respirator to breathe for him? Additionally, how will his spinal cord damage affect his sensations? When we covered the back in the previous lesson, we saw that some of its superficial muscles are actually muscles of the upper limb. Several muscles on the anterior and lateral chest are also upper limb muscles, specifically the pectoralis major and minor, the serratus anterior, and the subclavius. These aren't designed to move the bones of the thorax. Rather, they move the arm or the pectoral girdle, either the scapula or clavicle. The pectoralis major muscles, often called the pecs, take origin from the sternum and clavicle and insert on the anterior humerus. Because the pectoralis major is located anteriorly, it flexes the humerus. Also, because it crosses the axilla, pectoralis major adducts the upper limb, pulling it toward the body. And lastly, since it attaches to the anterior side of the proximal humerus, the pectoralis major acts in medial or inward rotation, rolling the head of the humerus toward the body. The pectoralis minor, on the other hand, originates entirely on the axial skeleton, typically on ribs 3, 4, and 5. It inserts on the coracoid process of the scapula, which we'll study with the bones of the upper limb. The pectoralis minor mainly acts to stabilize and depress the scapula. So both pectoralis muscles act on the upper limb. Their actions are not on the chest itself. We'll cover the medial and lateral pectoral nerves that supply them when we study the brachial plexus. The serratus anterior is a muscle of the lateral chest wall, and as its name implies, it has a serrated or jagged origin, mostly off of the true ribs. Remember, those are the first 7 ribs. It inserts on the deep and medial border of the scapula and is supplied by the long thoracic nerve off the brachial plexus. As an antagonist to the rhomboids, which retract the scapulae, drawing them together, the serratus anterior pulls the scapulae apart, often called protraction, or occasionally termed abduction. It also holds the scapula to the rib cage and can rotate the scapula to allow the upper limb to reach past the horizontal plane, which we'll discuss more with the upper limb lessons. The subclavius is such a small muscle that I sometimes say blink and you'll miss it. It helps to hold the clavicle down to the first rib and gets its own tiny little branch of the brachial plexus as its nerve supply. Remember that ventral rami have 2 possible fates. They can either assume a simple pattern in the thorax as intercostal nerves traveling between ribs, or they can braid into a plexus, such as the cervical or brachial plexus. Because the pectoralis major, pectoralis minor, serratus anterior, and subclavius are all upper limb muscles, they're supplied by branches of the brachial plexus. But because of its relevance now, let's examine the cervical plexus. It's a network formed by the ventral rami of the 1st cervical nerve through the 4th cervical nerve. The C1 or 1st cervical nerve comes out between the skull and the atlas. The C2 nerve comes out between the atlas and the axis. The C3 nerve comes out above the 3rd cervical vertebra. And the C4 spinal nerve comes out between the C3 and C4 vertebrae. So ventral rami of cervical nerves emerge above their corresponding bone. But you may recall that there are 8 cervical nerves and only 7 cervical vertebrae. This is because the C8 nerve comes out between the C7 vertebra and the 1st thoracic vertebra. From the thoracic vertebrae on down, all spinal nerves come out below the bone of the same number, at least until we reach the sacrum. Anyway, the ventral rami of the first 4 cervical nerves, C1 through C4, form a braided network on each side. As all spinal nerves are paired, all plexuses are bilateral as well. The cervical plexus has several cutaneous nerves that emerge off of it. Remember that cutaneous nerves are those that reach the skin, and although they have multiple functions, they primarily take sensory information from the peripheral nervous system toward the central nervous system for interpretation. The 4 main cutaneous branches of the cervical plexus are the great auricular nerve, the transverse cervical nerve, the lesser occipital nerve, and a group of supraclavicular nerves. Now, the lesser occipital nerve is a braid made of the ventral rami of the 2nd and 3rd cervical nerves, but so are the great auricular and transverse cervical nerves. So why different names for these? The answer is because of their different receptive areas of the skin from which they head toward the central nervous system, carrying sensory information. Auricle is another name for the external ear, and the great auricular nerve ascends from the cervical plexus to receive sensations from skin around the ear. Transverse cervical means across the neck, and its branches supply skin across the anterior and lateral aspects of the neck. The lesser occipital nerve supplies the lower scalp, posterior to the ear. And finally, the supraclavicular nerves are a bundle of cutaneous nerves formed by the braiding of ventral rami C3 and C4. As their name implies, supraclavicular branches supply the skin of the neck just above the clavicle or collarbone. But in addition to cutaneous branches that reach the skin, the cervical plexus also has 2 important motor branches. One is a strange and unique structure called the ansa cervicalis, which is Latin for loop of the neck. This is made from the ventral ramus of C1 that connects with the joined ventral rami of C2 and C3, forming a loop-like complex of nerve branches. Together, tiny branches off this loop supply most of the infrahyoid muscles and carry C1 ventral rami fibers to one of the 4 suprahyoid muscles. The other major motor branch off the cervical plexus is called the phrenic nerve. It's a combination of the ventral rami of cervical nerves C3, C4, and C5. This is a vital nerve that travels from the cervical plexus down through the thorax by clinging to the pericardial sac around the heart. Together, the right and left phrenic nerves supply the respiratory diaphragm. Now, I could talk all day about how awesome the diaphragm is, but for starters, do you know that it's only found in mammals? Yes, we mammals invented the diaphragm. We're cool like that. It's a shelf of skeletal muscle that separates the thoracic cavity from the abdominopelvic cavity. And so it's a rare example of skeletal muscle that's inside of and spans our ventral body cavity, rather than being outside of or in the walls of a body cavity. The respiratory diaphragm is also unusual in that it's a muscle that inserts on itself. It has fibers originating from all around the inside of the rib cage, along the thoracic wall, almost like the spokes of a wheel. Its insertion is a large median area of the muscle, known as its central tendon. Now, when the diaphragm is at rest, it is dome-shaped, and the muscle fibers are relaxed. But when our brain stimulates the phrenic nerves, and they in turn stimulate the diaphragm, the muscle fibers shorten and the dome shape of the diaphragm goes flat, sort of like tightening a drum head. This increases the vertical dimension of the thoracic cavity. And as you may remember from physics or chemistry, Boyle's law states that when you increase volume, you decrease pressure. So air rushes into the lungs following this high to low pressure gradient. How much air? About 500 milliliters in the average person, which is the volume of a standard disposable, or better yet, recyclable water bottle. Another unusual aspect of the diaphragm is its rhythmicity. It is skeletal muscle, but it's programmed for regular contractions and relaxations, whether we're asleep or even unconscious. Yet it is still voluntary skeletal muscle, since we can choose to inhale or exhale at any time. We don't have other skeletal muscles that have such rhythmic contractions and relaxations like the diaphragm. This normal, quiet, diaphragmatic breathing is known as our tidal volume, since that 500 mils of air comes in and out like the tide, with barely perceptible movements of the chest wall. But what about when we want to take a deep breath, perhaps to hold our breath and swim across the pool? That kind of breath takes in more than the approximately 500 milliliters of air taken in during a normal diaphragmatic breath. Deep breaths, whether in or out, require chest wall muscles known as the intercostals. As the name implies, the intercostal muscles travel between and connect the ribs. There are three main layers to these muscles of the rib cage: the external intercostals, internal intercostals, and what I call the innermost complex of chest wall muscles. The external intercostals have their fibers oriented down and in, like putting your hands in your pockets. In anatomical terms, we would describe them as from superolateral to inferomedial. The external intercostals can elevate the ribs for forceful inhalation. When this happens, the rib cage expands in a lateral or horizontal direction, further increasing its volume, and thereby decreasing its pressure, so even more air rushes in. This rib motion is often called a bucket handle action, since the ribs move like lifting the handle on a bucket. How much more air? It somewhat depends on a person's size, but it also depends on how they train themselves, whether like Houdini holding his breath for his great escapes, or a swimmer or other athlete who trains their lungs and heart along with their muscles. The internal intercostals have their muscle fibers perpendicular to the external intercostals. In other words, the internal intercostal fibers are oriented in a superomedial to inferolateral direction. Because of this, the internal intercostals can pull the ribs together during exhalation or expiration. So during forced exhalation, like to blow out the last few birthday candles on a cake, especially at my age, your ribs are pulled together, decreasing the volume of the chest. When the chest volume decreases, the air inside the lungs is put under increasing pressure, so air is forcefully expelled. We'll see shortly that we can also recruit our abdominal muscles to expel even more air. During normal, quiet breathing, when only the diaphragm is used, the chest circumference really doesn't change. In fact, normal, quiet breathing doesn't cause any observable surface motion at all. This is because the diaphragm is an internal shelf of muscle. However, if you take in a very deep breath, you can see, feel, and measure your rib cage expanding in a lateral or horizontal direction. If you want to try this, put a tape measure around your chest at armpit level. Measure first during relaxed, quiet breathing, and then take in a big, deep breath, hold it, and measure again. External intercostals increase the horizontal dimension of the chest for deep inspiration. Even some neck muscles, like the sternocleidomastoid and the scalenes, can help when someone takes a really deep breath. Try this yourself. Watch in a mirror and take note of the muscles in your neck. The first 500 mils taken in is from the stimulation and flattening of the diaphragm. Then we recruit the external intercostals to elevate the ribs in that bucket handle action, which expands the horizontal dimensions of the chest. As inhalation continues, some of the neck muscles can even raise the upper ribs and sternum to bring air into the topmost areas of the lungs. This final action is sometimes called a pump handle action because the sternum and upper ribs are elevated like raising the handle on an old water pump. Even the pectoralis minor muscles that normally move the scapula can be recruited to help raise the upper ribs. Now let's talk about the innermost complex of chest muscles. This deepest layer really consists of three subcomponents. On the deep side of the anterior rib cage is the transversus thoracis muscle. It's an interesting, almost star-shaped muscle that attaches the deep side of some anterior ribs to the posterior side of the sternum. The transversus thoracis is said to aid deep expiration. Then laterally are the innermost intercostals, which have roughly the same fiber direction and function as the internal intercostals. The third member of the innermost complex is found on the deep side of the ribs posteriorly. These are called the subcostales or subcostal muscles. These posterior muscles are still inside the rib cage, but unlike the innermost intercostal muscles, the subcostales span two ribs, not just one. There's also a group of muscles called the levator costarum, which are on the posterior side of the ribs, deep to the erector spinae, but lateral to the transverse processes. I didn't mention those with the back muscles, but they are supplied by dorsal rami, yet as their name implies, can also elevate the ribs to aid deep inspiration. Perhaps more familiar to many of us are the abdominal wall muscles, or abs, comprised of the external oblique, internal oblique, transversus abdominis, and rectus abdominis. Anatomically and developmentally, these are a continuation of the pattern seen in the intercostal muscles. In fact, the fiber directions of the external and internal oblique muscles in the abdominal wall match those of the external and internal intercostals. In addition, like the transverse thoracis of the innermost layer of the chest wall, the deepest layer in the abdominal wall is the transversus abdominis. It's as if the pattern continues, we just run out of ribs. But in places where they both occur, the abdominal wall muscles superficially overlap the intercostals. The external oblique muscles originate on the lower 8 ribs, and like the external intercostals, they also have their fibers down and in like hands in pockets. The internal oblique muscles have their fibers perpendicular, or down and out, you might say, similar to the internal intercostals. The internal oblique and transversus abdominis both originate on the thoracolumbar fascia of the back, the hip bones, and from an inferior structure called the inguinal ligament, which I tend to think of as the rolled hem of the abdominal wall muscles. The transverse abdominis also takes part of its origin off the costal cartilages of the lower ribs, and as its name implies, it has muscle fibers in a transverse direction, like a belt at the waist. Now, we have no anterior bones from the sternum to the pubic bone, so the external oblique, internal oblique, and transversus abdominis muscles all insert on their companion muscle of the opposite side. Now, this reinforced midline is called the linea alba, Latin for the white line. These 3 more laterally placed abdominal wall muscles reach that midline, linea alba, by large flat tendons called aponeuroses. They only have muscle fibers laterally in the body wall. The final muscle of the anterolateral abdominal wall, the rectus abdominis, is actually encased in these aponeuroses of the other 3 paired abdominal muscles, forming what's called the rectus sheath around the rectus abdominis muscle. The fibers of the rectus abdominis are vertically oriented, And this rectus sheath aids the rectus abdominis in its key role of flexing the spine as in a forward bend. This is partly because the anterior part of the rectus sheath, made of the aponeuroses of the other abdominal muscles, is attached to the rectus abdominis muscle by a series of transverse bands of connective tissue. These are called the tendinous intersections of the rectus abdominis muscle, and they're what give well-muscled people that so-called six-pack look to their anterior abdomen. Most people have 3 or 4 of these tendinous intersections in each rectus muscle. So if anything, it's really an 8-pack or a 10-pack, though I've heard some people refer to their jiggly, non-muscled belly as having come from too many 12-packs. That's a beer or soft drink joke, take your pick. The fitness buffs among you know that exercises like sit-ups, crunches, and side bends, with or without the aid of a weight machine, can strengthen the muscles of the abdominal wall to get that six-pack. In addition to flexing the spine, the rectus abdominis shares one function with the other 3 abdominal wall muscles, and that is compression of the abdomen. This action aids in childbirth, defecation, or forced exhalation, since compressing the abdomen can force the abdominal cavity contents inferiorly or push the diaphragm more superiorly into the thorax. But compression of the abdominal wall is the only function that all 4 abdominal muscles share. And it's the only function of the transversus abdominis, which is the deepest of these. Due to its orientation and midline insertion, the external oblique can also cause contralateral rotation of the spine. This means when the left muscle is used, it turns the right side of the torso, including the right shoulder, towards the midline. On the other hand, the internal oblique engages in ipsilateral rotation, meaning you use the right one to turn the right side of the body towards the midline. Now look at the fibers of the left external oblique and compare them to the fiber direction of the right internal oblique. The directionality is the same. So when we turn our right shoulder to the midline, we're using our left external oblique along with our right internal oblique. Remember, the direction of a muscle's fibers, its grain, tells you a lot about its function, and the left external oblique's direction matches that of the right internal oblique. And what about the innervation of these abdominal wall muscles? They are primarily supplied by intercostal nerves, the ventral rami of thoracic nerves. As we get to the most inferior reaches of the abdominal wall musculature, down by the inguinal ligament, the first lumbar nerve also gets involved. I mentioned that inguinal ligament is like the rolled hem of the oblique muscles. It's not a true ligament, but rather the conjoined edges of the external oblique, internal oblique, and transversus abdominis. The inguinal ligament extends from the anterior superior iliac spine, that's the prominence most people just call their hip bone, and attaches anteriorly to the pubic tubercle, a bump on the pubic bone of the pelvis. In people with well-developed musculature and little body fat, it can also often appear as a band in the crease between the torso and the thigh. While we're talking about the pelvis, do you know that we have 2 other shelves of skeletal muscle that span regions of other body cavities? Far less familiar to most people are the pelvic diaphragm and the urogenital diaphragm. Now, the pelvis is a ring-type bony structure composed of the 2 hip bones and the sacrum and coccyx. The pelvic diaphragm, or pelvic floor as it's sometimes called, is a funnel-shaped group of muscles that closes off the large passageway through the pelvis to support our pelvic organs, especially the tail end of the digestive tract. In fact, the rectum and anal canal are essentially the outlet of this funnel-shaped diaphragm. The pelvic diaphragm, subcomposed of the levator ani and coccygeus muscles, both made of voluntary skeletal muscle, fuses with the smooth muscle in the walls of the digestive tract to help ensure that the terminal part of the digestive tract doesn't prolapse through the pelvic floor. The other shelf of skeletal muscle in the pelvic region is the urogenital diaphragm. It sits just inferior to the funnel-shaped pelvic diaphragm anteriorly and supports the urinary and reproductive outlets, which pass through an anterior opening in the pelvic diaphragm known as the urogenital hiatus. A hiatus is a natural gap in a body structure. The urogenital outlets are one and the same in males, as the male urethra is a combined urinary and reproductive passageway, but they're separate in the urethra and vagina of females. After these urinary and reproductive outlets come through the hiatus in the pelvic diaphragm, they're supported at a more inferior level by the urogenital diaphragm. And both the pelvic and urogenital diaphragms can be injured in childbirth. You may have heard of Kegel exercises, which are squeezing type motions used to help strengthen these pelvic floor muscles. One of the skeletal muscles making up the urogenital diaphragm is the external urethral sphincter, which is the circular muscle that allows both males and females to control the flow of urine. We have an internal urethral sphincter of involuntary smooth muscle that relaxes when the bladder is full. But when children are potty trained, they learn to control the voluntary skeletal muscle of the external urethral sphincter that belongs to the urogenital diaphragm. Though not part of the pelvic diaphragm, there's also an internal anal sphincter made of smooth muscle and an external anal sphincter of skeletal muscle that's used to control bowel functions. With everything we've learned in this lesson, let's return to our clinical scenario. It described a young man whose C6 and C7 vertebrae were crushed in an accident, injuring the related regions of the spinal cord. The questions posed ask whether he would be able to do normal, quiet breathing or would be on a respirator, and whether he could take a deep breath beyond normal tidal volume, and if sensations from his skin would be affected. As we approach this clinical correlation, remember that except for those supplied by cranial nerves, the spinal cord is a conduit that relays motor information from the brain to most muscles of the body. In addition, the spinal cord also relays sensory information to the brain from all areas of skin below the head. Those sensations actually occur in the brain. In other words, when we touch something, we don't actually feel it in our hand, we feel it in our brain. But it's the receptors in the hand, the nerves traveling up the upper limb to the spinal cord, and the pathways in the spinal cord up to the brain that allow for that feeling. Recall also that particular patches of skin supplied by a given spinal cord level are known as dermatomes. Now, do you remember the muscle of normal, quiet breathing? What nerve supplied the diaphragm? It was the phrenic nerve off the cervical plexus. Do you recall the spinal cord levels of the ventral rami that compose the phrenic nerve? If not, then you can always use this mnemonic device. C3, 4, and 5 keep the diaphragm alive. So this guy will be able to breathe on his own, which is a major quality of life difference from being on a respirator. But how about taking a deep breath? What muscles allow for deep inspiration? The external intercostals, which are supplied by thoracic nerves. So the answer is sadly no. Signals from his brain will no longer be able to cross the area of serious damage in the cervical region of the spinal cord to reach those thoracic nerves. This means impulses from the brain will not stimulate any of the intercostal muscles. So this man will be unable to take or expel a deep breath. Additionally, will this injury affect the man's sensations? Well, intercostal nerves not only control muscles, they also supply the dermatomes of the anterolateral thoracic and abdominal walls. For generalities, the T4 intercostal nerve supplies skin at the nipple level. The ventral ramus of T10 relays sensations from the skin of the umbilical level, and the skin of the groin is supplied by the ventral ramus of the first lumbar nerve. The intervening nerves can sort of be penciled in between those levels. But what about levels above the intercostal nerves? Remember that cutaneous nerves of the cervical plexus, like the great auricular and supraclavicular nerves, come from C2, C3, and C4. So these areas supplied by nerves above the C6, C7 level of injury will retain sensation. As we'll see, the brachial plexus is composed of the ventral rami of C5 to T1. So those levels create the dermatomes on the shoulders and upper limbs. Ultimately, this man will have some loss of sensation in his upper limbs, but some will remain. However, he will also lose motor control over some muscles of and within the upper limb because the brachial plexus will be affected. And given it was the spinal cord that was damaged at the C6 and C7 levels, the dorsal rami of spinal nerves below the level of injury will also be affected, not just the ventral rami. So this young man sustained a devastating injury. He will have limited sensations from his upper limbs and will feel nothing from the chest on down. He'll be considered a quadriplegic since his upper limbs will have limited and impaired movements, and his trunk and lower limb muscles will also lose their stimulation from the brain. However, due to the diaphragm's supply by the phrenic nerve off the cervical plexus, he will be able to breathe on his own, and hopefully can learn to use a motorized wheelchair and perhaps even to drive, as did an old friend of mine who sustained a very similar injury in a swimming pool accident. From time to time, I'd like to pause and acknowledge just how complex and fragile the human body is, but also how resilient it can be. I'm proud to help my physical therapy students learn to assist people like the man in this case and improve their quality of life. And I hope the knowledge you're gaining improves the quality of your life too. In the next lesson, we'll review what we've covered in lessons 7 through 11 using the anatomage table to move three-dimensionally through the human body. Remember, the images you'll be seeing depict an actual human cadaver. So if you've got kids around or you just aren't comfortable with that, you can always jump ahead to lesson 13. But I really think that seeing beneath the skin will aid your understanding.